Today, our topic of discussion is non-union. Last day, I have teach about the normal bone union. Now, when this normal bone union is hampered by any means, and after a speculated time duration, the FDA approved time duration is minimum 6 to 9 months, but it can vary in different bone like scaphoid, neck femur, talus, except those bone. For normal long bone, non-union will be established when after 6 to 9 months there is no sign, clinical, radiological and biological, no sign of union, that is called non-union. Now, clinically, there will be frank movement which will be painless, and clinically sometimes there will be palpable gap. So that will be called as non-union, and that movement will be in abnormal position. Suppose joint is movement is normal, but above the joint if there is any movement, that is called abnormal painless mobility, and the compression and the palpable gap in the factor site after 6 to 9 months of duration. If there is no clinical radiological sign of union, that will be stamped as a non-union. Now, factor for non-union: first is improper immobilization, second is anemia, low albumin, vitamin C deficiency, vitamin D deficiency, smoking is very important factor for bone healing. If maximum smoker patient going to non-union, and infection also cause non-union, but sometimes in infected bone union can occur, but in infections due to infection there is a chance of non-union. Now, and diabetes mellitus also a predisposing factor for going to non-union. And most important, I told you in the last teaching that bone is a tree in the soil of soft tissue. So blood supply of any type of uniting bone is very important. So where the blood supply will came from the soft tissue coverage and the endosteal blood supply. Now, in case of fracture, the endosteal blood supply is lost. So the soft tissue surrounding this fracture will be very important. So bad soft tissue coverage is one of the most important cause of non-union in case of open fracture. Now, there are different types of non-union. Suppose radiologically, if you can see there is a gap and there is a elevation of the fracture end or widening of the fracture end, is called elephant foot hypertrophic non-union. And here mobility is the main factor for non-union. Here vascularity is good soft tissue coverage, but improper immobilization. In that case, the treatment is rimming and putting wider nail. That's all. No need to do any bone grafting or any other debridement, something else. Now, another type of non-union is oligotrophic non-union. Oligotrophic non-union, there will be gap in the fracture site, and this is called oligotrophic non-union. Here vascularity is good, but main problem of this non-union is gap. If you have to put any compression over this, that will going to unite easily. And last but not the least, there is the type of atrophic non-union, where there the vascularity is very less, soft tissue coverage is also very poor, and thick fibrous tissue around that, and so this is called atrophic type of non-union. Bone is going to sclerose and atrophic. So this type of fracture needs wide debridement and the sclerosed bone to be trimmed up. Then we have to put the bone graft. Otherwise, this atrophic non-union we never going to union. and the special variety of non-union is pseudarthrosis. Now there will be a small class over pseudarthrosis, but for undergraduate level you just know if there is any fracture, and for the long term if and this fracture site become a pseudo joint, means there will be a capsule, there is a synovium, there is a synovial fluid. So this type of fracture site become a joint, but it is a pseudo joint. This is called pseudarthrosis. Sometimes due to infection in the long bone in adult there is a chance of pseudarthrosis, and sometimes there is a congenital pseudarthrosis, lack of cambium layer over that periosteum also, and there are bad fibers of tissue. And regarding the non-union, I just draw a picture at very beginning. I am giving the explanation of this. The main factor of non-union is blood supply and improper stabilization. So any fracture, like there is some predisposing area like distal part of tibia is a very prone area for going to non-union, and in our rotavic accident maximum cases we get this type of fracture, may be open, may not be open, but whatever we have done, any type of implantation or any plaster, this area are more prone to going to non-union. Why? Because congenitally this lower one third of the tibia periosteum cambium layer may be defunct. Second, this lower part of lower one third of the tibia is subcutaneous. It has very least soft tissue coverage. All the muscle of the leg, it has a belly and it has a long tendon. Lower one third, all the muscle belly come to tendon. So all the avascular tendinous structure just surrounding this bone, and 2/3 of the bone is subcutaneous, not covered by any muscles, only tendons. So vascularity around this area is very critical. So any insult on this area may predispose to non-union early, and tibia has odds to going to non-union, and treatment protocol is very difficult. Why? Because tibia is associated with fibula. Sometimes tibia fracture is associated with fibular fracture. Now fibula easily unite, but due to fibula unite or fibula not fracture, the height will be maintained. Now any bone loss or any type of if there is a issue in the fracture side, then due to this height, this is fixed, so gap will be maintained. As a result, that due to fibular union or fibular no fracture of the fibula, this chance of non-union of tibia is very high. Now, where are the most common site for non-union? Neck of femur fracture. Within 3 weeks, if there is no sign of union, then we can, or any displacement, we can call it as a non-union. And the complication of non-union is avascular necrosis of the neck and wasting of the erosion of the neck. Now, scaphoid fracture is a fracture where the proximal part of the bone is going to non-union or sclerose, and because the peculiar blood supply, the blood supply come through the distal part, then it traverse to the proximal part, and it so if there is any fracture in the waist, the chance of non-union in the proximal part is very high, so it going to sclerose, and for this there will be a secondary osteoarthritis changes in the wrist joint. I will show it later. Talus has a also peculiar blood supply. That blood supply come through the head and it come into the neck body. So if there is any fracture in the neck, it's called aviator fracture. This fracture in neck, that blood supply will be hampered, so body of the talus going to non-union. So remember the talus fracture also easily going to non-union if there is neck talus fracture. So early fixation is very important this type of fracture. Humerus fracture. Humerus fracture is very notorious fracture for going to non-union. 30% of the humerus fracture, all humerus fracture, whatever treatment modalities like plaster, like nail, like plate, whatever, 30% of the case may go to non-union. So for any type of humerus fracture, when you are treating this patient, you have to counseling of that patient and family member that chance of non-union is very high and may be associated with radial nerve palsy also. So you have to counsel the patient. Even there is no radial nerve palsy after the operation, as there is a spiral group, so radial nerve is very close. So any operation or any manipulation can cause radial nerve palsy. Sometimes if there is any fracture over the lower 1/3 of the radius, the radial nerve will go entrap in the fracture. This is called Holstein-Lewis palsy. The high radial nerve palsy, low radial nerve palsy occur in this. High radial nerve palsy occur in this region is called Holstein-Lewis palsy. But you have to remember the due to improper immobilization, the chance of non-union in humerus shaft is very high. Now, another fracture is called lateral epicondyle fracture. This is most commonly found in the pediatric age group. You know, the lateral epicondyle, there is a epiphyseal center, and if there is any fracture over this area, actually this blood supply from the lateral epicondyle, if you show from the a lateral view of this humerus, this is humerus lower end and this is lateral condyle. It has a special angle towards anterior side. Now blood supply come to the from the posterior side and it will give this type of blood supply. Now, so if this blood supply comes through this and then comes this area, so if there is any fracture, then this part will be hampered, or any operation if you do, you have to put a humerus posteriorly, you have to humerus anteriorly, then already there is a fracture, then you have to putting a humerus over there, so this blood supply will be hampered. As a result, this will be going to non-union. So lateral condyle is very notorious for going to non-union in case of pediatric age group. So what are the complications of non-union? First complication is avascular necrosis, which is found in the neck of femur fracture, scaphoid fracture, talus fracture. Now, deformity in the case of lateral condyle epicondyle fracture, and then if as this non-uniting fragment is going to migrate, the joint line will be tilted. So valgus deformity will be occur. Cubitus valgus deformity will occur, and long run it can cause tardy ulnar nerve palsy. Tardy ulnar nerve palsy. What is tardy ulnar nerve palsy? Due to stretching and ballooning appearance of the ulnar nerve over the middle condyle, in the long term there will be ulnar nerve palsy, like clawing like this. This is called tardy ulnar nerve palsy. And last day we have discussed about Tillen sign. In this case also we can found Tillen sign because in this area due to attenuation of the nerve that and boosting effect, if you put any tapping over the middle condyle, you will get tingling sensation, and the nerve will be hand will be like this, partial clawing is called tardy ulnar nerve palsy. And it is a complication of progressive valgus deformity due to non-union of the lateral condyle fracture. So you just see the complication where to where, and believe me, the treatment of non-union is very difficult, because there each and every surgeon has his learning curve. From very beginning, if you will do mistake, you will not train properly, but when you get the training, already you are treating many patients, so chances of non-union is very high. So the treatment protocol of the non-union is very difficult, must be treated by the most senior most and experienced most teacher. And I told you the scaphoid fracture going to sclerose, and it can cause wrist secondary way, and hip also involved in this fracture. So this is the all total of non-union. Now we are going to the treatment option.